It's my pleasure to introduce Dr. Michael Jackson. Dr. Jackson is a Kaiser Permanente, he's at the Kaiser Permanente Washington Health Research Institute, and he's a principal investigator for the United States Influenza Vaccine Effectiveness Network. So Dr. Jackson's research program focuses on understanding how infectious diseases spread and on designing and evaluating interventions such as vaccination programs. And he also has an interest in advancing methodologies to assess vaccine effectiveness. So we're lucky to have Dr. Jackson today. I think it's very apropos with our current pandemic and to hear more about vaccine designs and vaccine effectiveness studies. So we're going to save the questions till the end of the presentation. And just as a reminder, this will be recorded and posted on the website. So thank you very much. And Dr. Jackson, the floor is yours.
Great, thank you. And thank you very much for the invitation to speak here. I've been looking forward to this. As was mentioned, I'm an infectious disease epidemiologist by training. And prior to 2020, most of my work focused on influenza and other respiratory pathogens. As you can imagine, since last March, it's been all COVID all the time. And as also was said, work at Kaiser Permanente Washington Health Research Institute, which is a large managed healthcare system in the United States. And it's a great place for doing this kind of work because we have integrated data on enumerated membership population and access to medical record data and administrative data on our population. And we're part of the United States Influenza Vaccine Effectiveness Network, as was mentioned. This is a collaboration of 5 US sites and the US CDC to look at how well flu vaccines work every year. And we're also part of what's known as the Vaccine Safety Data Link, which is a collaboration between 9 sites and the US CDC to look at post-licensure surveillance for vaccine safety events. And today I've been asked to talk about the test negative design, and in particular talk about how this design might be useful for doing studies of the effectiveness of COVID vaccines now that those are out and available. So just want to briefly set the stage here and talk about what this design is. It's a kind of observational epidemiologic study, and it's a variant of the case control design. The way it works is that you start by identifying patients who are seeking care for an illness that's consistent with your target disease. So if we were talking about influenza vaccines, our target disease would be influenza, and we'd be looking for patients that are seeking care for influenza-like illness or an acute respiratory illness. We'd then try to enroll all the patients that consent and are eligible into the study and test them all for the disease. Those that test positive are our cases, those that test negative then become our control group, our comparison group. And we compare the prevalence of influenza vaccination, our prior exposure in this case, between both of those groups. And this is a bit different from what we would think of as a traditional case control study. In a traditional case control study, we would use this mechanism perhaps to identify our cases and figure out who actually has influenza. But then we would go to some external population to get our control group. So we might do community-based sampling from the places the cases are from in order to get controls, or we might do hospital-based sampling to find people that have conditions hopefully not related to flu or flu vaccines in the same hospitals as we're getting our cases from. Doing our study this way, this test negative design, gives us a couple of advantages. So one advantage is operational efficiency. That in the test negative setup this way, you get both your cases and your control group using the same recruitment process and the same enrollment. So you don't need to have a second effort to go out and get your control group, compared with a more traditional case control design. It's also more efficient than a cohort study where you think about having to prospectively enroll a cohort of patients and follow them over time and figure out who develops the disease of interest. It also has the advantage, which I'll talk more in detail about in a few minutes, about some improved control for confounding. That we know that people that tend to seek care when they get sick tend to be different from those that don't seek care when they get sick. And those differences can include the likelihood of preventative interventions like vaccinations. In the test negative design, we are restricting our whole study population to patients that have sought care for illness of a similar acuity. And so by design, we're essentially stratifying on some kind of care-seeking behavior within our study population. And so we're reducing some bias that way. I want to briefly talk about the motivation and where this design originally came from and was developed for. And that comes from the world of influenza vaccine effectiveness. As I'm sure many of you are aware, influenza viruses are constantly undergoing mutations in the genes that encode for the viral surface proteins. And these mutations eventually accumulate into changes in the shape or the conformation of those surface proteins. And those changes can eventually lead new virus variants to escape immunity that was generated against older variants. We can envision this through a process we call antigenic cartography. This comes from a paper by Trevor Bedford and his colleagues looking at different influenza viruses. And it's essentially a way of visualizing how these viruses change in their surface proteins over time. So if you look at the top half of this figure where we have H3N2 viruses, on the top left, we have this Hong Kong 68 virus. And then for a couple of years, all the viruses that we would identify for H3N2 were antigenically similar to that Hong Kong 68 virus. Until at some point we get this kind of jump forward in time to this England 72 virus that's a little bit antigenically distinct, and then 75, and so on down into the future. And at some point along this chain of evolution, these newer variants are going to be able to evade antibodies that were generated against older variants. And so someone that was potentially immune to Hong Kong 68 could be reinfected by influenza with one of these later variants. And what this means for influenza control is that if we want people to maintain immunity against influenza, we need to revaccinate them whenever a new viral variant emerges. In practice, the way this works is that we offer influenza vaccines every year, and we update the strains that we put in the vaccine whenever it looks like a new variant has shown up. And so this is obviously a very big public health investment in purchasing annual influenza vaccines and distributing them to large swaths of the population. So good stewardship suggests that we should have some ongoing monitoring of the vaccine programs and how they're working in practice. We know that there's a couple reasons why influenza vaccines can fail. One is that we can get a mismatch between the strains that go in the vaccine and what actually shows up and circulates. Because of the lead time we need in order to manufacture and distribute vaccines, there's typically 8 or 9 months between when we have to decide which strains go into the vaccine and when flu actually starts circulating. And so we have to guess 9 months in advance which strains are going to circulate next year. And occasionally we can guess wrong. In those situations, sometimes the vaccine might be poorly effective or ineffective against the mismatched strains. And we've also seen that flu vaccines can fail sometimes in unexpected ways. And so we need to have these monitoring systems in place to identify when that's happening and to try to course correct. And it's interesting that even though flu vaccine programs are decades old, before the early 2000s, nobody was doing this. Nobody was trying to look at flu vaccines on an annual basis and make sure that this year's vaccine was working the way we'd expect. So actually, the Canadians were the first ones to get into this. And back in the 2004-2005 season in British Columbia, the British Columbia Center for Disease Control tried to do the evaluation of how well that year's vaccine was working. At the time, they had an existing surveillance system for influenza, where they had a number of providers would report every week what % of their patients were coming in for influenza-like illness. And they could track that over time and see basically when flu season was peaking based on those data. For this season, what the British Columbia Health Department asked them to do would be also to enroll some of these patients in a study and look at whether they've been vaccinated or not, and to try to collect some respiratory swab specimens to test for influenza and submit those to the health department. And the CDC then used those data to try to estimate how well the vaccine was working. And they actually, for this, used a test negative design, which I believe is the first use of this particular variant of the case control study that I've been able to see in the literature. Interesting that at the same time, the same year, a similar process was going on in the United States. The Marshfield Clinic in Wisconsin was asked by CDC to pilot test the idea of doing yearly flu vaccine evaluations. And they had a similar process to what was going on in British Columbia. They had surveillance for patients seeking care with influenza-like symptoms and enrolled them and tested them for influenza. But in our case, they were doing a traditional case control study. So they got their influenza patients that way, but then they went into the greater population of Marshfield to randomly sample controls. And what they found that season was a very low influenza vaccine effectiveness, around 10%. And they weren't able to get these results published and out in the literature because nobody believed influenza vaccine effectiveness could be that low. The reviewers were all assumed that there must be some problem in the way the Marshfield team selected their control group. in order to get a VE of 10%. And so it wouldn't be accepted. And I want to take a slight digression here and talk about why there's belief that flu vaccines had to be really effective in these populations, because I think it's a good example of what can happen in epidemiology when we follow the processes and the procedures or go through the motions, but don't really think critically about the results that we're giving. So in the 1990s and through the mid-2000s, there were a number of different studies looking at how well flu vaccines worked in seniors. And these studies had a couple of things in common. Even though they were conducted by different research teams in several different countries, they were all using large administrative healthcare databases to define their patient populations, to look at who was vaccinated, who had the outcomes, and at potential confounders and comorbid illnesses. And they also had in common that they all used non-specific outcomes, things like pneumonia, which influenza can cause, but can also be caused by many other things, or all-cause mortality, so death from any cause. This graph shows a forest plot of a number of these different studies looking at all-cause mortality. And although there's heterogeneity there, you can see all these studies are finding odds ratios or hazard ratios less than 1, so apparent protective effects of the vaccine. And the median across a number of these studies was around 50%. And given that there were a large number of these studies published and they were all giving more or less consistent results, it was pretty well accepted that flu vaccines can prevent 50% of all deaths in seniors during flu season. And again, these studies look like they're doing all the right things, using large databases, controlling for underlying health conditions based on ICD-9 or 10 codes, and coming up with these consistent results. But if you step back and think about it, in order for flu vaccine to prevent half of all deaths in seniors, it means that flu has to cause at least half of all deaths in seniors. And in 2005, Loni Simonson and her colleagues did a study where they tried to estimate how many deaths in seniors were caused by influenza each winter. And over about a 30-year period, they found that there's year-to-year fluctuation, but that flu was never associated with more than 10% of all deaths in seniors. And the median across all these years was about 4%. So that means that if flu vaccines were working perfectly, we'd expect 4% VE against all-cause mortality. So these estimates of 20 to 50 or 80% reductions in mortality are clearly not plausible and must be the result of some kind of bias. And some further research by groups like Lisa Jackson was able to show both that there's bias there and why this bias is happening. And just really briefly, what was going on is that there's what we call a healthy vaccinee bias, where seniors who are younger and healthier are more likely to get flu vaccine and less likely to have outcomes like pneumonia or death. This is some data from their paper where they looked at seniors that died versus those that didn't, and did some chart review to find markers of frailty. So things like living in a group home or needing assistance walking or bathing or having dementia. And they found that seniors that had these frailty markers were much less likely to be vaccinated than other seniors and much more likely to die. So vaccination, if you don't control for this frailty, is going to falsely look good because the unvaccinated have a much higher risk of death. And they also found that ICD-9 codes that were being used to define these confounders don't actually identify frailty in seniors. So in this particular table, they looked at a number of seniors that had no ICD-9 codes for any of these diseases listed at the top, so cancer, diabetes, dementia, and so on. If we just looked at ICD-9 codes, we'd say these seniors are perfectly healthy. They don't have any underlying conditions. But then actually going into the medical records, we find that among those that, or cases, those that died, over a third had things like dementia or needed assistance bathing, needing home health services. Almost half lived in a non-home setting. Over half needed assistance with walking, and so on. So these seniors were very frail based on what we could see in the records, but that wasn't showing up in the automated data. And so, quote unquote, adjusting for these variables doesn't actually remove the healthy vaccinee bias. So it took until kind of the mid 2000s for the realization to come in that these prior studies of flu vaccine effectiveness were strongly biased. And that didn't mean the vaccine doesn't work. It just meant at that point we didn't know how well the vaccine worked. And so there started to be acceptance for the idea that maybe you could have a low vaccine effectiveness in a particular year. But so at this point in time, Ed Belongia and his colleagues in Marshfield, Wisconsin, were still essentially casting around, trying to find a different control group that they could use in order to demonstrate that their results were correct, not the result of bias in the selection of controls. And then in 2007, we had the first paper describing the methodology behind the test negative design. So this is by Evan Ornstein and colleagues. And Gaston Desserres, the second author there, was also co-author on that first paper out of the British Columbia CDC looking at flu-VE using the test negative design. And so this was a study that was comparing the effects of imperfect influenza testing on VE estimates from 3 different study designs, including a test negative study. So it wasn't a deep dive into the methodology, but was at least putting it out there as a method in the literature beyond the studies that are being done in British Columbia. And so when Ed Belange and his colleagues saw this, they realized that they could be using this design with the data they had been collecting in their pilot study. And so then they went back and really analyzed 3 seasons worth of data using a test negative design. And so with that improved control group and with the growing realization that maybe there's more to the flu vaccine story that needs to be investigated, they were then able to get this published. And there's a paper there for that. Meanwhile, while this was happening, the British Columbia team was still going ahead with the surveillance. So there's a paper from them from the 2005-2006 season. And this was then expanded to a multi-province network in Canada, looking at, again, flu-VE using the same test negative design. And between the 2 groups, this really hit a tipping point in terms of the realization that this kind of study was both economically feasible and was giving was a good method for doing this kind of estimation. And so this design really started to take off in popularity. So in the US, the pilot study was then expanded to a multi-site network. And we started seeing other networks showing up in other countries as well. So the iMove collaboration in Europe has several different components, but one is a multi-country test negative study of influenza vaccine effectiveness. Australia put together the FluCan network starting in 2009. More recently, there's a network of several Central American countries that are looking at influenza VE using a test negative design, and New Zealand and so on. And if we just look at the frequency of the phrase test negative design in titles and abstracts submitted to PubMed, you can see that around 2010, this really started to take off in popularity. It's also been applied to other vaccines as well. So we've seen this design used for rotavirus vaccines, for oral cholera vaccines, and dengue vaccines. But one thing that's really interesting in the history of this is that this design became the de facto standard for these national or international networks around flu vaccine effectiveness without actually ever having the methodology for it laid out, that people started using it and discovered that it worked and seemed to be giving good and valid results, but without ever really laying out the theory behind it or the assumptions that are going into it. And so in the 2011-12 season, our team at Kaiser Permanente joined the US Flu-VE network, and CDC asked us if we could try to lay out actually what's going on with this design and what the assumptions are involved with it. And so it's a paper from 2013 that our team put together. So Jen Nelson and I worked on this. And we're going to walk through some of the tables from the paper that illustrate what this design is doing and the assumptions that are involved. So we could start with a hypothetical population here. We imagine that we want to estimate influenza VE, and we can stratify people based on whether they've been vaccinated or not. And we can consider 2 different kinds of people. So we can consider one strata of people that would seek care if they got some kind of respiratory infection, and another strata that would not seek care if they had a respiratory infection. And then within those groups, some people are going to get infected with influenza, some people might get infected with something else, and some people will never get infected. For now, we'll make a simplifying assumption that this care-seeking proclivity is binary. You either do or don't seek care. Later on, we can show that can be relaxed. This is mostly for illustrative purposes. But one of the 2 keys here, one is that care-seeking, this kind of proclivity for seeking care, is likely a confounder in estimating VE, because people that seek care are more likely to get vaccinated, and they're also much more likely to be detected as having influenza if you're conducting any kind of clinic-based surveillance. So it's something that you ideally would want to measure and control in some way. But the other point here is that we know that this is actually very difficult to measure, the sort of care-seeking proclivity, and to use existing data or interview questions, try to figure out which strata people would fall in is really hard to do. So we have two challenges then for doing VE estimates in this population. So one is that really we only observe care-seeking behavior in people in these cells here, A, B, G, and H, people that both got infected with something and are the kind of person that would seek care. So we don't observe, we don't know that the people in cells C and I are the kind of person that would seek care if they got infected. The other problem here is that if we're doing some kind of clinic-based surveillance or hospital-based surveillance for influenza, we don't observe people in cells D and J. So these are people that got influenza but didn't come in and seek care and get detected by our system. And so these problems will have implications for a traditional cohort or case control study. In a cohort study, we can imagine taking some sample of the full population, and then we stratify people based on whether they're vaccinated or not. And we could look at clinic visits and try to find who gets influenza in those groups. And then we could estimate VE as the risk ratio or the rate ratio of people who get flu, so cell A divided by the total population, N1 and N2, compared to in the unvaccinated G over N3 plus N4. And we have two problems here. So the first problem is that these estimates are confounded by healthcare seeking behavior because we can't really measure and control for that. And the second problem is that we have misclassification. So people in cells D and J are being considered part of the denominator when they should also be in the numerator as having influenza, but we haven't detected them. We have the same issue if we do a traditional case control study. So we identify people that come into the clinic and get tested and are found to have influenza, and those people are cases. And then we take a random sample from the rest of the population and make those our control group. And again, we're confounded by healthcare seeking, which we can't measure very well. And we have misclassification that people in cells D and J are considered controls when they should be cases. So now let's think about an idealized VE study. And we'll start with one assumption here, that we'll assume that there might be confounding by care seeking, but there's no effect modification by care seeking proclivity. So we assume that the vaccine works equally well if you're the kind of person that would seek care if you got sick, or if you're the kind of person that wouldn't. So if we make that assumption, then in theory, we could look in either strata of care-seeking behavior, so either in the people that would seek care or the people that wouldn't, and estimate the risk ratio for influenza between vaccinated and unvaccinated, and get an estimate of VE, and those should be the same across both those groups. So we can imagine doing a hypothetical study just in the kinds of people that seek care and estimate our risk ratio there and get an estimate for vaccine effectiveness. So if we could do this, we wouldn't have confounding by care seeking because we only have one strata of the care seeking group. And we don't have bias by misclassification because people in cells D and J that would have sought care, that would not have sought care if they got sick, aren't in our study population. But we can't do this particular study because we can't identify the people that are in cells C and I. We can't distinguish them from the other people that would not seek care if they had gotten sick. So now let's make a second assumption. Let's assume that the incidence of respiratory illness due to other pathogens, so not influenza, is the same between our vaccinated and unvaccinated groups. So this means that the risk of in the vaccinated of B over N1 or B over the total population is the same as the risk in the non-vaccinated of H over N3 or H over the total population. So with this assumption, this means that the ratio of H to B should be the same as the ratio of the full population sizes. So if that assumption holds, then we can substitute in this ratio of H to B for the denominator sizes in our cohort study that we can conduct in this just among the care-seeking people and get the same VE estimate. So this is the test negative design. We only need to identify people that seek care for respiratory illness and divide them into whether they have influenza or something else. And we're using the non-influenza group and the ratio of vaccine prevalence in that group to represent the expected ratio in the total population. So in order to make this work, again, we're making two main assumptions. we're assuming there's no effect modification by your proclivity for seeking healthcare. The vaccine works the same regardless of whether you would seek care or not. Now, we don't need to have this strict assumption that there's only two kinds of people, care seekers and non-care seekers. We can imagine that there's a range of thresholds of illness above which people would seek care. But we do assume that among individuals that have a similar threshold for care seeking or similar proclivity for care seeking, the incidence of non-flu respiratory illness is the same in your vaccinated and unvaccinated groups. And of course, then we need all the usual assumptions of any observational study design, so exchangeability and independence and so on. But these are the key ones that make this design work. So I want to now talk about some of these assumptions and some of the particular wrinkles that go into a test-negative design study and how those might play out if we were using this design to study COVID vaccines. So a test-negative design for COVID vaccine would look something like this. We would define syndrome of COVID-like illness, or CLI, and identify all the patients that are seeking care for that illness. We'd enroll those that are eligible and consent into the study and test them all for SARS-CoV-2. Those that test positive are the cases, those that test negative are the controls, and then we compare the prevalence of vaccination between those two groups. So the first wrinkle that we have is the idea of information bias. So information bias is the fact that we don't measure our outcomes or our exposures or confounders perfectly, that we have some error in those measurements. One way we can get information bias is due to imperfect influenza or SARS-CoV-2 testing. So we know that no lab test is perfect. We can get false negatives and false positives. And that misclassification is going to cause bias in our studies. And the bias actually turns out to be a little bit worse in test-negative studies than in a comparable cohort or case control study. So this is some simulations that Ken Rothman and I did a couple of years ago to look at this. So look at 3 different designs: cohort, standard case control, and test-negative, and 3 different kinds of influenza tests you could use. So a hypothetical perfect test with no misclassification, RT-PCR, which is highly sensitive and specific, or a rapid antigen test, which is highly specific, so it doesn't give a lot of false positives, but has maybe lower sensitivity, so might give false negatives. And look at the effects of these different biases on these different studies. And what this table shows is that for any given level of misclassification, the test-negative study does a little bit worse than the cohort or case control study. So let's see, using PCR test, assuming a true VE of 50%, we see that the cohort study is a relative bias of about 6%. So they estimate 40% VE compared to the true VE of 50%. Whereas the relative bias in the test-negative study is about 8%. And if the test gets worse, so it has more false negatives, the relative bias for the cohort study was 20%, same for the case control study, but 26% for the test-negative study. And the reason for this is that in a traditional case control study or a cohort study, you're only applying this misclassification to the group of the small part of the study that comes in to get tested and is found to be cases or not. You're not applying the testing to your comparison group. Whereas in the test-negative design, everybody's getting tested. So you're getting the impacts of reduced sensitivity and specificity are affecting both your case and your control group. And so you get a little bit higher bias that way. So we think about applying this to SARS-CoV-2 vaccines. Our understanding is that influenza RT-PCR is extremely sensitive and specific, so probably better than 95% sensitive, probably better than 98% specific. So both false positives and false negatives are pretty rare for flu PCR. It looks like SARS-CoV-2 PCR is a little worse than that in terms of performance. The systematic review back in October found that sensitivity of PCR for SARS-CoV-2 ranged somewhere from 75 to 100% across a number of studies, and specificity from 88 to 100%. So comparatively, it's probably not as accurate as influenza testing. So if you're doing a test-negative study of SARS-CoV-2 vaccines, you need to be aware that the performance of the test may be causing more bias relative to other designs you could be using. And so possibility of either using other control groups or at least doing some sensitivity analysis around your test characteristics and how that might be impacting your estimates is going to be important. Information bias can also affect the measurement of your exposure, so your vaccination status. And this is another set of studies, simulations that we did looking at the effects of mismeasurement of vaccination status in influenza test negative studies. The top figure here is looking at varying the sensitivity, so the having false negatives where you falsely call vaccinated people unvaccinated. And at least in influenza vaccinations, so the typical levels of vaccine coverage and incidence that we find in those studies, we found that sensitivity wasn't all that impactful. So you'd have to get pretty low sensitivity of your vaccine measurement in order to cause meaningful bias. But that specificity was much more important. So falsely calling unvaccinated people vaccinated could pretty quickly have a big impact on your VE estimates. So for SARS-CoV-2 vaccines, if you're doing these kind of studies, getting good vaccination data is going to be important. Hopefully that this won't be as squirrely as influenza vaccine assessments. That's flu vaccines are notoriously difficult to get a handle on. People don't remember very well if it was this year or last year that they got vaccinated. And at least in the United States, people can get vaccinated in a number of different settings, some of which may or may not report their results into vaccine registries. So some can be harder to verify than others. Hopefully for COVID vaccines, people are all quite aware of whether they got them or not. And hopefully records are more complete, but it is something to be aware of that's missing. Falsely classifying people's vaccination status can have meaningful bias. The second broad issue within test negative studies is handling of calendar time. And there's two separate things here. So the first is that diseases like influenza are highly seasonal. So there's parts of the year where the virus is circulating a lot in the population. And there's other parts of the year where the virus is essentially absent and people really aren't at risk for influenza. If you're doing a test negative study, you could be enrolling people before influenza shows up or after the end of influenza season. And because there's not really influenza, all those people would be counted as controls, as not infected. But if you include those people in your VE estimates, you're essentially causing a mortal time bias. This would be equivalent in a cohort study to counting person time in the exposed or unexposed groups when people actually aren't at risk for the outcome. So what you want to make sure that you're doing is that you're only recruiting people that test negative into the study during time periods when the virus is actually circulating and you are getting positives as well. The second issue with calendar time is that you can have overlap in the time periods when people are getting vaccinated and when you're actually enrolling people, and your disease incidence can be changing over time. So if we look, here's some data from Canada, number of vaccine doses distributed by day versus new SARS-CoV-2 cases by day. And so you can see that your relative probability of getting vaccinated or having SARS-CoV-2 looks very different in early January compared to early March. So calendar time is related both to your probability of having been vaccinated and to the likelihood that you'll end up with SARS-CoV-2. So calendar time is a confounder then, and you'll want to control for that in your analyses. A third issue relates to this assumption that the rate of your non-COVID, COVID-like illness needs to be the same between your vaccinated and unvaccinated groups. This is the assumption that this comparison group of people that don't have the target disease and make up your control group represent the full population. And in order to try to make sure this assumption holds, there needs to be careful thought given to the case definition of what gets you into the study. And this is particularly true in inpatient settings. If the case definition is too broad, then your patient population ends up including a lot of people that are being hospitalized for exacerbations of chronic conditions and not really for potential acute respiratory illness. And this is a study here that illustrates that out of Spain. This was looking at the effectiveness of the monovalent 2009 pandemic influenza vaccine against the swine flu virus. And I don't want to pick on the study. This was early on before we knew a lot of the characteristics of the test negative design. And so probably didn't realize what might be happening here. But this was done in hospital settings, and the case definition that would get someone into the study was very broad. So there's a number of conditions here that you would expect to be complications of severe influenza. So fever, acute respiratory infection, signs and symptoms, shortness of breath, maybe some radiologic signs. But there's a lot in here that could be caused by other things as well that may be much less likely influenza. So metabolic or multi-organ failure, altered mental status, diarrhea, vomiting, those kinds of things. And the result of this very broad case definition was that the cases and controls ended up looking very different in terms of the distribution of underlying conditions. So here cases are in the yellow and controls are in the green. And you can see that controls were much more likely than cases to have things like cancer, immunodeficiency, or renal failure, and so forth. So what's happened by having this very broad case definition is that the study by design has essentially reintroduced this bias by underlying health status. So the controls and cases are very different in terms of their chronic diseases and probably their likelihood of vaccination as well. And this was seen in their VE estimates. They estimated that the vaccine was 90% effective at preventing hospitalizations due to the 2009 H1N1 virus. And from everything that we know about influenza vaccines, that's implausibly high. And this is probably the reason for it, is having this broad case definition. So if you're doing a study of COVID vaccines, especially in a hospital setting, it's important to make sure that your case definition is tight enough that you're not getting a lot of chronic disease exacerbations in there. But just a couple of final thoughts on this, sort of in general with these studies. It's important not to let clinicians decide who gets enrolled into a test negative study, that you want to have some standardized enrollment criteria based on clinical signs and symptoms and try to get everybody that meets that criteria. Because clinicians may be making decisions about which patients to test or which patients to recommend for the study based on the physician's perception of how likely it is they have the target disease. So we worried about this with influenza, that if the physician says, oh, this person's been vaccinated, they probably don't have flu, I'm not going to test them for flu, or I'm not going to recommend them be in the study, that could be introducing some systematic bias. So sticking with standard criteria is going to be important. And the final thing that we can be really watching for is, wherever possible, trying to use negative control outcomes to assess the presence of bias. A negative control outcome is something that is related, is not related to the exposure of interest that you can look at and hopefully find no relationship in your data between that outcome and your exposure. So for studies of SARS-CoV-2 vaccines, we could hopefully use something like influenza as a negative control outcome. And that would look something like this. So we'd have our same setup where we enroll patients that are seeking care for CLI. And then those that we enroll, we would test them both for SARS-CoV-2 and for influenza. And so now we have some different groups of our patients. So we have those that test positive for SARS-CoV-2 are our cases, and people that test negative are the controls. And so then, as usual, we would estimate vaccine effectiveness comparing the prevalence of vaccination between the SARS-CoV-2 cases and the negative controls. But then we'd also have a group of people that test positive for influenza and not SARS-CoV-2. And we could estimate the effectiveness of COVID vaccines against influenza, comparing the influenza positives to the controls. And what we'd be hoping for is to find 0% VE in that group to make sure that our method is working well. And if we see a VE that's not 0, that's an indicator that you probably have some kind of either uncontrolled bias or residual confounding that needs to be adjusted for. And this can be a really useful tool for identifying those in ways that we might not otherwise see. So that is a review of the test negative design and ways that we could apply it to studies of COVID vaccines. Thank you for the invitation and for your attention, and I believe there is time for questions now.
Thank you very much. Excellent talk, very fascinating. So we have time for some questions. You could either unmute yourself or put your question in the chat and I'll read it out loud.
Hi, this is Maria Sundrum. I'm at ICES in the University of Toronto. I wanted to thank you so much for this talk. Even after having worked on the test negative design for quite some time, it's really wonderful to see this. I'm wondering if you could comment or share your thoughts on studies that enroll individuals attempting to find both SARS-CoV-2 and influenza infection, and what you would propose the sort of length of symptom from symptom onset to like test eligibility criteria might be. And please let me know if that was an incoherent question. It sounded incoherent to me, but hopefully you can understand.
No, that's great. It's good to hear from you, Maria. Yes, so we have some evidence that people may shed SARS-CoV-2 for longer than they shed influenza. And so people may be reasonably expected to test positive for SARS-CoV-2 further out from illness onset than for influenza. When we do these studies in influenza networks, we typically cap our enrollment at 7 days post-onset because we worry that after that, people may have actually had influenza, but not be shedding enough virus to be detected by PCR anymore. So if you're testing for both in a test negative study, you could either have sort of different cutoffs for when you would count people in the analysis based on which way you're going. You could say, for the estimates of COVID vaccine effectiveness, we might go out to 10 days post onset. People are still eligible, whereas we'll just restrict to people that are within 7 days of onset for flu. Or potentially you could just make that an enrollment criteria at the beginning. Just keep it to the earlier stages where you think you're more likely to find positives for both. I think unless you had reason to suspect that people that are far out from onset for COVID are somehow different from those that are closer in onset that might be causing bias in some way, then having a longer enrollment period appropriate to SARS-CoV-2 and just restricting your negative control analysis to the reasonable period for influenza is probably a good way to go.
That makes perfect sense. Thank you.
Okay, great. We have one question in the chat from Peter. Is this design the same as a nested case control design where the nesting cohort is those subjects with a given health-seeking behavior?
Yeah, so I'll give the definition that I'm familiar with for nested case control design, and you can clarify if there's a different definition, because I know it's been applied to some other kinds of studies. So when I think about a nested case control study, I think about having a full cohort that you've been following and have information on, but then within that, identifying your cases and sampling controls for a particular analysis. This is often used where you might need additional data on for confounders or exposures that might be more expensive to get than you can get in the full cohort. So it's a little different conceptually because in this case, we don't necessarily have a fully enumerated cohort that we're recruiting from. We essentially can be recruiting anybody that comes into a clinic or a hospital for care. And it is kind of a nice design to use, particularly in places where we don't necessarily know what the catchment area of our hospital is. And in a traditional case control study, you would really need to know what your source population is in order to go out and get controls. Whereas with this design, we basically, because everybody's seeking care at the hospital, both our cases and our non-cases are coming from the same source population, even if we can't fully enumerate that.
Okay, thank you. Any additional questions?
Yes. Mike, thank you so much for this and for clarifying a lot of these issues. Recently, there was a study from Israel looking at the effectiveness of, I believe, the Kaiser vaccine in a very traditional cohort approach, a cohort of 600,000 patients vaccinated matched to 600,000 patients not vaccinated. And I believe in that cohort, not everyone was tested, whereas in your design, everyone is tested, so we know whether they have or they do not have the infection. So how do you weigh one against the other in terms of potential accuracy of the estimates?
Right. Yeah. So I think the full cohort study does have the issue of you may have people infected in either group that you're not detecting, and so there's the misclassification there. And I think that could be particularly an issue if your vaccine might potentially not prevent infection, but prevent the severity of illness. So there may be some people that got infected, but wasn't enough for them to come in and get tested in the vaccinated group. So I think that can be causing bias. I don't know enough though about testing and care delivery in Israel to know how big an issue it is. That if there's if you're in a situation like we have been in a pandemic where there's at least the desire to do lots and lots of testing for anybody with symptoms, and if you're in a setting where that's relatively easy to get, and you think that you're not missing a lot of infections, then the relative bias of that might be fairly small. And so then the advantages of being able to have a larger cohort and get at least some statistical power that way would be helpful. But I think it would be at least nice to see in parallel a more test negative approach to the analysis. And again, I think on the flip side too, right? The downside of the test negative is you do get some extra information bias due to the sensitivity and specificity issues. So I think running it both ways and hopefully getting a consistent story with perhaps offsetting biases would be nice to see.
Right. Thank you. Yeah, I do believe that if you do have the full cohort, then it would be a good idea to try this design that you presented within that full cohort to try to see issues, but just as a sensitivity analysis, I think it would make a very good sensitivity analysis. And by the way, as a comment, yes, your description of the nested case control study is exactly what it is. And thank you again on behalf of CNODES, by the way, for this talk.
Yeah. Thank you. We have one question in the chat from Hanuk. How valid is the assumption of no effect modifiers with health-seeking behavior? Do you think patients with health-seeking behavior might also apply other social distancing and sanitizing measure, which increases the effectiveness of the vaccine?
So in that case, I wouldn't think that measures like wearing masks or social distancing are going to improve how well the vaccine works. It's just going to reduce the number of exposures you have that might be prevented by vaccination. And so an advantage of the design is that if people that, again, tend to be the kind of people that seek care, tend to be the kind of people that get vaccinated, probably they're going to tend to do some similar kinds of preventative activities together. And so you're more getting just a narrower set of strata of different kinds of behaviors in your study population and being able to control for those. So I wouldn't expect that to be a source of effect modification for the vaccine effectiveness. I think for COVID vaccines, the place I would worry about is that obviously we have been targeting vaccines towards high-risk groups to start with, and a lot of those high-risk groups are your older and your more frail populations. And if there's heterogeneity within those groups about, among all people 65 and older, who's getting vaccinated versus who's not, it could be that you're still getting younger, healthy people that are more vaccine hesitant and may have other differences as well there. That would be more of a concern.
Okay, thank you. We have a question from Razan.
Yes.
Go ahead.
Thank you for this great talk. I'm Razan from the University of Waterloo. I'm a PhD candidate here. I know you've touched upon the frailty variable or the factor, and you did mention it also coming up when attempting to measure vaccine effectiveness in cohort studies. But with test negative designs, would you be considering controlling for frailty while measuring vaccine effectiveness, or you would think about removing frail patients from your study sample in order to measure vaccine effectiveness?
Yeah, that's a great question. So in our experience in outpatient settings, we've tried to measure frailty in different ways. So for example, in the US Flu V network, we ask patients over 65 and older whether they have issues with walking or some other things like that. And in those settings, we haven't ever found that trying to adjust or control for that makes a difference in our estimation. So I think within the population of people that can get in for routine outpatient care, that hasn't been a very strong issue. I haven't personally done a lot of work in hospital settings to know how much more common that is, but I think in those settings, it would be a lot more important to try to measure frailty in some ways and be controlling for that, because you might be expecting differences in care-seeking behavior by frailty groups there.
Thank you.
Okay, great. Any other additional questions? I guess I have one question. So I guess what would be the impact of the variants on the vaccine effectiveness, and specifically with respect to the test negative design? If you're thinking about, we're looking at these new variants which might induce more severe disease, do you think that there's less of this potential bias related to health-seeking behaviors? If it's more severe, more patients are going to get tested.
Yeah, that's a good question. I'm not sure how, so if the variant is both able to escape vaccine-induced immunity and also potentially cause more severe disease, then it may be exceeding more people's threshold for the point at which they seek care. Not sure offhand if that would improve or reduce your bias, but again, it would be if, among people that have a similar level of care-seeking behavior, that you have your incidence of other causes of seeking care is more or less the same.
Okay, great, thank you. We have a bit of time for maybe a couple of other additional questions.
Mike, it's Deshane Fell. Hi. That was a great presentation. I just had a question. I mean, you talked a lot about the fact that you sort of envision this study design as starting with individuals who are seeking care, who are coming forward with symptoms, either COVID-like illness or influenza-like illness. And in the case of flu, as you know, a lot of test negative studies are done using retrospective approaches, right? So using routinely collected lab data and other routinely collected data like a hospitalization database, linking them together. And so you don't really know a lot about the indication. And I mean, with flu, presumably a lot of most people who are tested are seeking care, but with COVID, a lot of hospitals are doing universal screening. And so those, you're picking up a lot of asymptomatic illnesses in routine lab data bases this time. And I'm just wondering if you could comment on how that may or may not impact your VE estimates compared with the flu situation.
Sure. Yeah, I know with flu, the concern about using those kind of retrospective data is related to physicians' preferences for testing. That if physicians are saying, well, this patient was vaccinated, so it's probably not flu, I won't order a flu test, then you could be systematically biasing your study sample. And I know that it's been some work done in Ontario that you've been involved with that has looked like, at least in that data system, that's not too much of a concern, which is great. But yeah, in terms of trying to use surveillance, specimens coming in for COVID, I think that could be a real concern if there's a mix of people that are getting tested because potentially they've been exposed but don't have any symptoms, or people that have to get tested to travel or to because of travel coming back from other places, or have to get tested for work in some way, would be a very different population from people that are being tested because they're symptomatic. And so would want to I think the ideal setting would be trying to restrict to some population where you knew what the indication for testing was. So, and that I don't know kind of specific data systems, how those play out. At Kaiser Permanente, we're able to look at the indication for someone getting a test ordered on them. And so we can restrict to people that have had a consulting nurse service call or a telehealth visit or an in-person visit in some way that we can verify this was coded as the person being symptomatic in some way before we would approach them for inclusion in a test negative study, or if we're doing this retrospectively using those data. But yeah, I think that could be a source of bias that you at least want to investigate and try to understand those different populations before lumping them together.
Thanks.
Okay, great. Are there any additional questions?
I see a question from Razan. So could you please comment on how influenza VE was impacted during the pandemic? Was it overestimated given the lockdowns occurred? Actually, we have not been able to estimate influenza VE because there hasn't been any influenza. It's the intervention measures, so both flu and SARS-CoV-2 are spread the same way, more or less. And so all the stuff that we do to slow down SARS-CoV-2 has slowed down influenza. And because influenza is less contagious than SARS-CoV-2, flu's been slowed down a lot more. So we have unprecedented lows in the number of people testing positive for flu over this past year. And the various networks haven't had enough flu cases to try to estimate how well the vaccine's working.
It's an interesting problem. Okay, any additional questions? I guess that's it. So I guess we'll leave it at that. So on behalf of CNODES, I'd like to thank you very much for your great presentation. It is fascinating, and I'm sure we're going to see more of these test negative designs in the near future. So thank you very much, and thanks to everyone for attending. Bye-bye.